Greetings from Forts. We welcome all doctors to this live webinar. We are honored to have esteemed doctors in this forum to talk about the benefits of multiple micronutrient supplementation during pregnancy. We thank Team Vitamin Angels and New York Academy of Sciences for joining hands with us to establish the concept of MMS, multiple micronutrient supplementation during pregnancy. Forts is in the pharma industry for the past 40 years, following the motto of innovating for good health. At present, we are exporting our products to over 50 countries around the globe. We have a wide range of products in gynecology and IVF segments. Our products cater from prenatal care to UTI therapy, and our brands are Prenatal, Argin, KMAC, and Ubica. I take this opportunity on behalf of Forts. We welcome our chairperson, Dr. T. Ramani Devi, MD DGO, FICS, FICOG, Managing Director of Ramakrishna Medical Center and Janani Fertility Center. Madam has won many gold medals and awards during her service. Madam is a National Vice President of FOGSI 2020. Madam is an International Advisory Board member of Fertility Society of Bangladesh. I also take this opportunity to welcome our moderator, Dr. Usha Viswanath, MD Professor and Head of Obstetrics and Gynecology, Sri Ramachandra Institute of Higher Education and Research. Madam is awarded the Diploma in Hospital Administration by National Institute of Health and Family Welfare, New Delhi. Madam has designed mobile app Suraksh for intrapartum monitoring of patients. Madam is the Secretary for UNESCO Bioethics Program of Srihar. Thank you, ma'am. Over to Ramani, ma'am, for further proceedings.
Thank you for the nice introduction.
Yes.
Yes, I'm very happy to be the chairperson of this prestigious program by Forts, where we are having international figures like Dr. Kristen Hurley and our local speakers, Dr. Usha Viswanath and I have today as a chief guest, Dr. Jaydeep, who's a good friend of mine. And I have great pleasure in introducing Dr. Jaydeep. Can I have the CV of Dr. Jaydeep? Usha, can I have the CV of Dr. Jaydeep?
Yes, ma'am. Just a minute, ma'am.
Yeah. I think the first 1,000 days of maternal nutrition are going to be very, very important. Not only the basics of carbohydrate, protein, or fat, but it's also the micronutrients which are essential for the development of the fetus, as well as when the baby grows up to till the woman breastfeeds the baby, mother breastfeeds, we need to have the essential micronutrients that are needed for the growth and development of the newborn. So this CME will be updating us on what are the current aspects of promoting the maternal nutrition so that we have a safe delivery as well as a healthy baby and a healthy mother.
Yes, ma'am.
Yeah. I have great pleasure in introducing Dr. Jaydeep, who is the Secretary General of FOGSI India. He is the immediate past president of Mumbai, and he is the international chair for Federation of Obstetric and Gynecological Committee for Safe Abortion, Deputy Secretary to Asia Oceanica Federation of Obstetric and Gynecology, and he has been awarded the FRCOG Honoris Causa in 2020 by the Royal College of OBGYN to be conferred in September 21. He is the ex-chair, Publication and Newsletter Committee of AOFOG and Reproductive Endocrinology and Infertility Committee of Asia Oceanica Federation of OBGYN. So he was also the MTP chair of FOGSI between the year 2004 to 2009, Vice President of the Forum for Enhancement of Quality of Healthcare, and he is the consultant at Ashwini Maternity and Surgical Hospital, Center for Excellence in Endoscopy and IVF, founder Esperanza Healthcare Private Limited, program director and member of board Profert IVF, visiting consultant in so many IVF centers across India. He is instrumental in drafting the proposal for FIGO, which has resulted in a grant of $13 million for 10 country projects, 8 in Africa and 2 in South America. And he's the technical lead for the project. He's currently working on developing the proposal for 6 country projects on menstrual hygiene in Asian countries for AOFOG. He's also working for the development of project of masks geared towards assisting underprivileged women in urban slums with their menstrual hygiene needs. Worked on the amendments of MTP Act with the Government of India, drafted the proposed guidelines for abortion beyond 20 weeks of Government of Maharashtra, part of the several technical advisory groups and committee of Government of India. Contributed to the electronic membership management system and e-voting for FOGSI, developing a completely redrafted user-friendly constitution for FOGSI, and contributed and led the development of the FOGSI statements on cesarean rates, hysterectomy rates, contraceptive implants, ART bill, surrogacy bill, etc. FOGSI's WPs and interventions in Supreme Court on PCPNDT. The IRIA case, the oxytocin case, and others, restructuring of the FOGSI cells, minutes of FOGSI MCM and GBMs, and several other initiatives. He has been quite active in FOGSI as a general secretary, and he has made so many changes in FOGSI and made the administrative things so easier in FOGSI. So let me wish him very smooth victory in his future endeavors. And thanks to FOGS for giving me this opportunity of introducing Jaydeep Tang. Over to Dr. Jaydeep.
Thank you. Thank you very much, madam, for that very kind, generous, and if I may say so, warm introduction. It is always such a pleasure to interact with you. For those who may not be aware, Dr. Ramani Devi, madam, is actually one of our most scholarly and erudite personalities in FOGSI. And she is now popularly known as the endometriosis lady because of her expertise and very significant work that she has done in the field of endometriosis. But I can, on a personal basis, share that her expertise is not simply limited to endometriosis, but extends almost to the entire obstetrics and gynecology. So thank you very much, Ramani Devi, madam, for that kind introduction. I have gotten to know madam very well, I think, over the last 1.5 years, and it's such a pleasure and real privilege to be working with her. Thank you for inviting me and for that kind introduction. I must say that I am quite honored to be here, not only because I've been introduced by Ramani Devi madam, but also because I believe I'm in the presence of some academic heavyweights, if I may say so, with Dr. Kristen, Hurley, Dr. Randi Chaudhary, and Dr. Usha Viswanath. I understand that the topics are extremely interesting, and I really would like the audience to get the most out of the deliberations which are going to follow. So after just saying that the importance of nutrition in the first 1,000 days, the benefits of MMS and role of multiple micronutrients in pregnancy has undergone something, if I may say so, of a revival. And I'm glad to see that this revival is more evidence-based rather than anecdote-based. You know, whenever patients come to us with their mother-in-laws, the mother-in-law always tells us, feed her this, feed her that. And then sometimes you have to tell them, it's important to feed them, but don't overfeed them. And I think that is a balance that one always tries to strive for, not only as a physician, but also as a woman who's carrying her pregnancy throughout the 9 months. So we are looking forward to these deliberations, Dr. Kristen and Dr. Ranadip, and of course, Dr. Usha, who's going to moderate, and Dr. Ramani Devi, who's going to chair. And thank you very much, madam, again, for that kind introduction and for having me here. Thank you.
Thank you, Dr. Jaydeep.
Thank you, madam. Thank you.
Madam, kindly introduce Dr. Kristen Hurley, ma'am.
Again, I'm very happy to introduce Dr. Kristen M. Hurley, who's the Associate Professor, Program in Human Nutrition, Johns Hopkins Bloomberg School of Public Health. She is the Senior Vice President of Nutrition Vitamin Angel Alliance. Dr. Hurley is a public health nutritionist. Her research and practice activities are described in 55 peer-reviewed publications, 4 book chapters, and 6 practice publications, and covers diverse aspects of maternal nutrition, including the micronutrient deficiencies during the first 1,000 days of life. Dr. Hurley is a steering committee member of Healthy Mothers and Healthy Babies Consortium. This consortium helps to harness the action and improve the maternal nutrition and globally. Dr. Hurley was recognized for her excellence in teaching for the delivery of nutrition and life stages course at Johns Hopkins University. As a Senior Vice President of Nutrition at Vitamin Angels, Dr. Hurley is responsible for translating scientific evidence to the public health nutrition expertise into effective programming activities within the health system. It's not only the doctors that we should know about the role of micronutrients in the maternal nutrition for the first 1,000 days, but we need to spread the message to all the mothers so that let us have a healthy mother and a healthy baby. Now, I welcome Dr. Kristen M. Hurley to deliver her talk on first 1,000 days of maternal nutrition.
Great, thank you so much. It's really an honor to be part of today's webinar, and I really thank all the organizers of FOGS for your kind invitation for me to present. Like I said, it's an honor to be here. So I just wanted to start off by saying good evening to everybody, and I can share my slides. Give me 1 minute. Okay, can you see my slides?
Yes, ma'am. Yes, ma'am.
Great, thank you. All right, so again, good evening, everybody. And my name is Kristen Hurley. And again, it's an honor to be part of today's webinar. And I just wanted to, I'm going to talk about maternal nutrition specifically as it relates to the first 1,000 days of life and the benefits of multiple micronutrient supplements. So just a quick outline of my talk today. I'm going to, again, talk about maternal nutrition as it relates to the first 1,000 days of life, highlighting the importance of micronutrients during pregnancy, and then summarizing at a global level the supporting evidence for the use of MMS, specifically Unimap MMS, which is a multiple micronutrient supplement that has 15 vitamins and minerals, including iron and folic acid. But I'm going to summarize the global evidence for the use of MMS in improving pregnancy outcomes, and then just talk a little bit about the global policy guidance, where that is right now for the use of multiple micronutrient supplements or MMS in pregnancy. So this is an image that I basically stole off from Nutrition International, but I just wanted to use it. We've heard a couple people mention the first 1,000 days, which most of you probably know is the period from conception to age 2. But I just wanted to take a second to just kind of highlight that the first 1,000 days, are really a tremendous, or a time of tremendous potential, but also an enormous vulnerability. How well or how poorly mothers and children are nourished and cared for during this time has a profound impact on a child's ability to grow and learn and thrive. And this is because the first 1,000 days of life are when a child's brain begins to grow and develop, and when the foundations for their lifelong health are built. Poor nutrition during the first 1,000 days of life can really cause irreversible damage to a child's growing brain, affecting their ability to do well in school and even earn a good living as an adult. And it makes it harder for a child and a family to rise out of poverty. And it can even set the stage for later chronic problems such as obesity, diabetes, and other chronic diseases. So this is, and I think it's really important to just think about, the importance of breaking this cycle of undernutrition that often starts and then comes back to this first 1,000 days of life period. So interventions that focus on this first 1,000 days of life, specifically in pregnancy, can really help to break this intergenerational cycle of an undernutrition, which is where, you know, an undernourished mother, for example, will give birth to a low birth weight baby, and then the low birth weight baby will grow to an undernourished child, and then an undernourished teenager, and finally to an undernourished pregnant woman. And the cycle starts all over again. One way to really help break this cycle is to help pregnant women meet their increased demands for micronutrients. Women have increased nutrient demands during pregnancy due to the rapid growth and development that is occurring during this life stage. We know that pregnancy is a time of nutritional vulnerability where micronutrient needs are increased to meet physiological requirements, to sustain things like fetal and growth and development, and also to help protect the health of the mothers during this period. We also know globally that many women are unable to meet their needs, and this can have, or their micronutrient needs, and this can have very negative consequences, not only for their health, but also the health of their infants. You know, in some, pregnant women have increased requirements for vitamins and minerals due to their rapid growth and development that occur during this life stage, and such as, you know, multiple micronutrients such as vitamin A, C, D, E, the B vitamins, and also minerals such as iron, zinc, iodine, copper, selenium. They're all increased during, the needs for those are all increased during pregnancy. We can see here on the right side, this table here just shows the prevalence of micronutrient deficiencies across several different regions of the world. And I think what's really interesting here is that, you know, there are, for example, there are, you know, you can see the white bar here, you know, high prevalence of like iron deficiency in many countries, but also a high prevalence of many of these other nutrients such as iodine, vitamin E, even vitamin A, and folic acid. So often when women are deficient in one nutrient, they often are deficient in many others. And again, you can see on this slide too that the prevalence of anemia is, you know, about 50% in many of these countries, and that's also what we see in India as well among women of reproductive age and of anemic women. So I wanted to also highlight here is basically, oops, sorry, I'm struggling a little bit with my. There we go. There has been a lot of work done over the last couple decades, a lot of different randomized control trials, about 33 different randomized control trials in countries all around the world that basically have looked at, you know, the benefits, the potential benefits of using multiple micronutrient supplements in pregnancy versus the standard of care, which is iron folic acid. And so just recently in the last few years, all this evidence has been summarized really nicely in, you know, a couple different Cochrane reviews. There was a really nice individual patient data meta-analysis done that was published recently in The Lancet that really showed the benefits of using multiple micronutrient supplements over iron folic acid on pregnancy outcomes. And just to give you a sense of what that evidence looks like, you know, both across these two different kind of summaries of the data, we saw benefits of MMS versus IFA in relation to the reduction of small for gestational age. We saw improvements in low birth weight, preterm birth, and also in stillbirth. And those benefits were even greater among nutritionally vulnerable women. So the benefits of the provision of multiple micronutrient supplements, or MMS versus IFA, on outcomes such as infant 6-month mortality, low birth weight, and preterm birth were even greater among anemic women or underweight women than the overall population of pregnant women. And I just, this is, it's basically showing the same thing, but it's a nice summary of where the evidence is right now based on all of those different randomized control trials. But basically, MMS and IFA has been shown to be equally effective at reducing the risk of anemia during pregnancy. But the benefits of MMS when compared to iron folic acid alone include, like I said, the reduction of the risk of stillbirth, especially again among nutritionally vulnerable pregnant women, such as anemic women. Also, the evidence shows the reduction of risk of mortality among 6-month infants, again, especially among anemic women, a reduction in the risk of low birth weight, small for gestational age, and also the reduction in the risk of preterm birth, especially among underweight women. When the WHO guidelines came out back in 2016, at that point, the WHO guidelines for nutrition interventions during antenatal care, they continued to recommend iron folic acid at that point, and they did, however, talk about the use of multiple micronutrient supplements in their recommendation. And at that point, they raised some concern about potential risk of increased neonatal mortality in those receiving MMS versus IFA. But again, given all the, given additional data and evidence that has been collected over the last few years, along with these kind of Cochrane reviews and meta-analysis that has been performed, the data at this point shows that there's no increased risk of neonatal mortality associated with multiple micronutrient supplements. There's also been a lot of, a lot of conversations have been happening about whether or not, MMS has fewer side effects than IFA, or if adherence for MMS is better or worse than it is for IFA. Adherence has always been a problem historically with the use of iron folic acid. It's even if you can deliver the iron folic acid to women, often ensuring that they take it on a daily basis so it can be most impactful is difficult. So there are a lot of questions whether the use of MMS may improve the adherence potentially by decreasing the side effects. There has not been a lot of research looking at this yet, and I think it's an area that needs further exploration. There also has been discussion about the cost of switching from the iron folic acid to MMS and whether it is cost effective, whether it's affordable. And there's been some research done here too. Even if the MMS product cost is assumed to be much higher, based on some cost effectiveness analysis done in a couple different countries, it's still shown to be very cost effective in terms of preventing daily adjusted life years and deaths, and also preventing negative birth outcomes. Having said that, it has been shown that MMS it has been shown in the recent years that it can be produced at comparable prices to iron folic acid. Nutrition International has done some great work. They created a tool that actually allows different countries to kind of insert data and look at the cost of effectiveness in their country of switching from IFA to MMS. And then I just, I basically pasted here some of what they've done for India in terms of showing, what it would cost potentially, and then how many, again, what are the benefits, and they were able to show that it would be very cost effective if there was a switch from IFA to MMS in India. Just wanted to, back up a little bit and talk about the WHO recommendations for nutrition during pregnancy. Obviously, they have recommendations around dietary counseling for healthy eating and appropriate weight gain during pregnancy. They continue to have a recommendation for iron folic acid. Just recently in 2020, they also inserted a context-specific recommendation for the use of MMS during pregnancy, and I'll talk about that in a minute. And then in some populations with high prevalence of undernutrition or calcium deficiency, they also recommend the use of balanced protein and energy supplements and also calcium supplements during pregnancy. There has been, as I said, there was a context-specific recommendation most recently in the WHO guidelines for the use of MMS. And really what that context-specific recommendations means has been further translated by UNICEF and other leading international organizations for country-level decision makers. And in this document, and here on the right, UNICEF basically clarifies that the introduction of multiple micronutrient supplements is to be done in the context of antenatal care services, if it's to be introduced, and it's to be done in a way that's informed by some kind of implementation research to at least work to make sure it's effectively delivered to try to ensure high coverage and adherence. So just a quick summary, again, in terms of the use of MMS versus iron folic acid. As I showed you, there's been a lot of research done over the last couple of decades. As it was mentioned before, it's great that we're working with evidence, but basically the research has shown that MMS is efficacious. There's strong evidence for its use towards the reduction in things like low birth weight, small for gestational age, preterm births, stillbirths, and even potential reductions in neonatal death. Also, the research to date has shown that MMS use is safe. There's no evidence for any serious adverse effects. It's also highly cost effective and also becoming affordable as well. So thank you very much. Yeah.
Thank you, ma'am. Yes, ma'am.
Thank you, Dr. Kristen Hurley, for your clear-cut messages regarding the use of multiple micronutrient supplementation during pregnancy. So you have highlighted that there is definite reduction in the preterm labor incidence, low birth weight, fetal growth restriction, stillbirth, and it goes beyond the incidence of neonatal mortality rate less than 6 months has been drastically, it can be brought down by supplementation with multiple micronutrients. It is, we don't need not only iron supplementation, but along with the iron supplementation, we need to give the patient with multiple vitamins like vitamin A, C, D, folic acid, pyridoxine, and cyanocobalamin. And along with that, tracer elements like iodine, zinc, copper, selenium, and calcium as a nutrient is also very much essential for the maternal promotion of this maternal health, as well as thereby promoting the fetal health also. So these drugs, when they are put together, they don't have any adverse effect, and the side effects caused by these drugs are not supposed to be very prominently seen, and it is cost effective when you compare the outcome. For example, if the patient is going to have a low birth weight baby or a stillbirth or a FGR baby or an early neonatal death, then the costs that are acquired because of treating these kinds of problems is going to be anyway much higher than simple supplementation of multiple micronutrients. Because one thing is, it's not only the cost, but it also takes away the psychological problems the pregnant woman and the family can undergo because of these maternal and fetal complications. I think it's very nice to hear the WHO guidelines have come regarding the supplementation, and it is found to be a very safe, efficient, cost-effective method of promoting maternal nutrition as well as reducing the fetal adverse outcome. Thank you for giving a clear-cut message.
Thank you. Thank you for the summary. That was terrific. Let me stop sharing. Sorry, I thought I did that.
Okay, I have great pleasure in introducing Dr. Randi Chaudhary, who is an MD and PhD, Assistant Director and Research Scientist in Society for Applied Studies, New Delhi. His areas of work include pre-pregnancy programs for improving birth outcomes and improved understanding of drivers of linear growth and metabolic syndrome during fetal life and early childhood, and also meta-analysis to update WHO guidelines for care of preterm and low birth weight infants and postnatal care. He has certain achievements, the recipient of BBT Welcome IA Intermediate Career Clinical and Public Health Fellow, and Global Nutrition Early Career Scholar Award by the American Society for Nutrition 2018. We all know that the role of micronutrients in pregnancy is a very, very important topic and equally contested topic. So over to you, Dr. Randi, to be speaking on micronutrients during pregnancy. It's over to you.
Yeah, thank you. Thank you. It's a great pleasure to talk in front of all of you. Let me share my slides. Maybe you will see some repetition because what Hurley presented, most of them, maybe I will emphasize this again, but I will do it in a different way. So there will be some repetition, but I think that repetition will be helpful for the physicians and practitioners because you can get the information. If you get the information, same kind of information twice in same session, it may help you to do the same thing in practical life. Okay, so let me share my screen. As introduced by Dr. Usha, myself, Dr. Ranadip. I am a physician and thereafter I have turned to a scientist. So what is the role of multiple micronutrient during pregnancy? So maternal micronutrient deficiency is an intergenerational cycle. And what do I mean by intergenerational cycle is that if pregnant woman has deficiency of certain micronutrient, they may have increased risks of mortality, themselves have increased risk of mortality or perinatal complications. Also, this micronutrient deficient pregnant women will have increased risks of low birth weight baby or small for gestational age baby or preterm baby. Now, this small for gestational age baby or preterm and as a combination low birth weight baby, this vulnerable group of infants will have or may have increased risks of say stunting, means length for age G-score less than -2 SD, or frequent risks of infection or reduced learning capacity. And when this group of children will come into adolescent, they may have reduced mental capacity and increased risk of infection. And then again, they will come to the same cycle of pregnant women and also in the adult, and that may have an impact on reduced productivity. So the summary of this slide is that we should not see a pregnant woman and is individual. The pregnant woman itself is the dyad of mother and infant and fetus. And when they deliver infants and that particular infants will grow up during childhood or adolescent, or they become adult, this imprint of micronutrient deficiency can persist through lives. So that's why this is an intergenerational cycle. So now let's come to role of this micronutrient during pregnancy, during the development of fetus, during this period of pregnancy. So as we can see from the x-axis that there are different phases like blastocytogenesis, embryogenesis, fetal development, and on the y-axis you can see the offspring, that is the fetus, the placenta, and the maternal and placenta. So different vitamins and different minerals will usually play significant role in from blastocytogenesis up to fetal development phase. And I will briefly describe about some of these. So the B vitamins, like the 1-carbon metabolism vitamin like B6, B12, and folic acid, they play a significant role during preconception and epigenetic effects. And this is very important to understand here because we always talk about 1,000 days life. Now the concept is coming that some sort of intervention need to be start from preconception, so that when this woman will enter into pregnancy, they should be micronutrient depletion, micronutritionally replete or nutritionally replete, because pregnancy gives you very short time to correct any deficiencies already there, because there is already certain additional requirement during pregnancy. So these vitamins play an important role here. Now let's come to see the implantation. During the implantation, apart from these vitamins, some key minerals are important: copper, selenium, zinc, and iodine. And here I want to emphasize a bit on selenium. There are studies recently have shown that selenium deficiency in early pregnancy increases the risk of preterm birth. So there are, and that may be due to the effect of this implantation. Then there is certain role of these vitamins and minerals for vascularization and hormonal production for placenta that we all know are very important. I don't need to tell about this to this audience. And also for nutrient transfer regulation. And here, apart from the vitamins, some key minerals also play important role, like copper, selenium, and zinc. Now let's come to the offspring part, that is embryogenesis and fetal development. For embryogenesis, morphogenesis, and organogenesis, and including vascularization, these play an important, some vitamins and minerals are play important role. And another important point I want to here emphasize, that is the neurological development. We all think, and sometimes we think that neurological development of infants starts after delivery or after birth. It's not true. It's not true. There are some this starts to happen when the baby is D vitamin and minerals play a critical role. So overall impression from this slide I want to give you that each micronutrient that is there already in the regime of UNIMAP has some key or critical role in either for the fetus or for the placenta or for the mother. So you all need to understand the biology behind the micronutrient supplementation when we talk about micronutrient supplementation. Now this slide already showed by Hurley. Just I want to here emphasize on the Southeast Asian part, as because we are part of that part of the region. So if you can see that most in Southeast Asia, most of these micronutrients like folate, vitamin B12, vitamin A, iodine, zinc, all are the prevalence are all high. All prevalence deficiencies are high. And among them, if you see the deficiency of, say, for example, zinc, the deficiency of, say, example, for vitamin D are almost 60-70%. And regarding anemia also, it is approximately 50%. So two issues. Number one, I have shown in the previous slide the biological importance of each micronutrient during the process from implantation to development, and then where we are regarding this deficiency. Now let's come to this about what is the effect. Now we know the biological possibility. We have seen the deficiency level prevalence. Now what is the available evidence? So regarding available evidence, what I want to share with you, as already shared by Hurley, that there were a lot of controversy, and the controversy were there till I may say maybe last 2 to 3 years. But from last 2 to 3 years, the things are being settling down because of these two systematic review. One by Cochrane and the second one by Smith, my good friend, Emily. They have done a individual participant level meta-analysis. But the information we are getting, or the conclusion we are getting from those two meta-analyses, are almost similar. There is almost, say, 3 to 8% reduction or decreased risk of small for gestational age babies, almost 10 to 12% decreased reduction or decreased risk of low birth weight babies. Even on one step further, the Emily individual participant data meta-analysis showed there is almost 7% decreased reduction of preterm birth. So when we talk about adverse pregnancy outcome, we talk about low birth weight and its two components, either small for gestational age babies or preterm birth. So the current evidence is strong enough to show that multiple micronutrient supplementation compared to iron or folic acid supplementation has a reduced risks of for all the three adverse pregnancy outcome. That is low birth weight, small for gestational age, and preterm birth. Now, if we go one step further to see whether these effects have any or more significant effect in some subgroups. So if we see that among the anemic women, so the women who were anemic, hemoglobin level less than 11 during pregnancy, if they get this multiple micronutrient supplementation, they have 19% more chance of low birth weight reduction and 8% decreased risk of small for gestational age reduction. And also, in addition to that, 27% decreased risk of 6-month infant mortality. And all these are higher compared to non-anemic women. So that means that those who are anemic, that means a more vulnerable group, if they receive multiple macronutrient supplementation, they have more beneficial effect compared to those who are not anemic. So this is a very important point we need to remember. Another important point, those who are underweight or say BMI less than 18.5, they are also another vulnerable group because these two groups have higher risks of adverse pregnancy outcome. So even in this group, those who are underweight or BMI less than 18.5, this group, if they receive multiple macronutrient supplementation, their reduced risks of preterm birth 16% compared to those who are not underweight. So these two vulnerable group of infants, vulnerable group of mothers, multiple macronutrient supplementation have shown more beneficial effect compared to those are not so much vulnerable. So these 2 points we need to remember apart from the overall effect. Now the third point about when to start, that is a very important point, when to start. So if multiple macronutrient supplementation starts before 20 weeks of gestation, they have 11% reduction of preterm birth compared to no change after 20 weeks. So starting point is important. Early part of pregnancy is important. And if you remember the slides where I have shown the impact of or the role of different micronutrients, you may remember that the initial period of blastocytogenesis, embryogenesis, implantation, their role are very critical. Now, another important part, and that has part for both the clinicians and the public health professionals like me or academicians, that compliance. You can prescribe, we can advise multiple macronutrient to one woman, but whether they are taking it or not, that is very important. So what is the data says? The data says that adherence, if it is more than or equal to 95%, they have shown that their reduction of neonatal mortality, important, neonatal mortality and infant mortality risks are much higher compared to if their compliance is less than 95%. So in addition to the overall effect, these 4 subgroups are very important for us, not only for the public health implications or public health policy, also for the day-to-day practice. Now, this slide, I will show a little bit about the individual macronutrient during pregnancy. There are some reviews. They have shown that vitamin D supplementation during pregnancy has reduced 45% of low birth weight, and also zinc supplementation, isolated zinc supplementation has almost 14% reduction of preterm birth. So this is the individual macronutrient supplementation. I will not go in so much details in it. Now, another question usually arises, and I hope in day-to-day practice also, and if you talk with a physiologist, biologist, or a nutritionist, they may say, if multiple micronutrients are supplemented during pregnancy and the particular woman is also taking some foods or daily diets, which has all these micronutrients, then what about the upper limit? What about the upper limit of this all micronutrient? And if this crosses the upper limit, whether we have any adverse event. So this study has shown very minutely that even if, and here I want all of you to focus on the blue bars, that is the WHO recommendation of recommended daily allowance and upper level. So if you see, there are 3 micronutrients if both taken from diet and from a standard multiple micronutrient supplementation, that is Unimap, 3 micronutrients may cross upper level, may cross. One of them is niacin, as you can see here, just 103% according to WHO guideline. And second one is just touching upper level, that is folic acid. And for iron, there is no blue bar here because WHO doesn't have any recommended dietary allowance for iron because it depends on the settings. Now, what is this implication? Let's discuss about this. Let's discuss first about the implication for folic acid. So excess folic acid may mask the vitamin B12 deficiency that we all know. But the advantage of multiple macronutrients is that multiple macronutrients already has vitamin B12. So there is the mitigation plan. Now let's come to niacin. It is 103%, that means 3% higher if both taken from Unimap and percentage upper level from diet. But for niacin, we need to understand that excess intake of niacin usually have an adverse effect related to flushing that may not have too much significance. And for iron, we all know that it depends on the settings, and in settings like India where already there is an iron deficiency anemia, so that may not be a too concern issue. So the message I want to say that when people will talk about that examining the risks of this macronutrient intake in pregnancy, if a woman is also taking upper level of all these macronutrients from diet, we need to concentrate on the issues, or we need to conceal the issues about that this is not so significant except for 3, and I have discussed about the issues of 3. So we are in a better position to supplement multiple macronutrients. This already Hurley has showed. I will not go in details of that, but just one point I want to mention here that recently there is a study they have shown that including the cost of manufacturing of multiple macronutrient or iron folic acid plus its implementation cost plus its facility cost, if all can be included, then cost of IFA supplementation per pregnant woman will be $15. Just keep it in mind, $15. And for multiple macronutrient, it will be $16.86. So it is a difference of $1.2 excess. But on the other side, if we think about the cost effectiveness, as we can see from the data shared in this slide, that cost per death averted would be $175 to $185 for Bangladesh, as because the study was done in Bangladesh and Burkina Faso, and cost per daily averted range from $3 to $15 depending on the country and consideration of the subgroup effect. So now regarding the WHO recommendation, WHO has recently revised its recommendation. In an early recommendation in 2016, it was specifically written that not recommended, but now WHO says in 2020 recommendation that antenatal multiple macronutrient supplementation that include iron and folic acid are recommended in the context of rigorous research. And there they also have put some remarks. One remarks that the recommendation is based on evidence derived from the trials using multiple macronutrient supplementation containing 13 to 15 macronutrients, including IFA, and that is widely available in Unimap, which contains 15 micronutrients, including 30 milligram of iron and 0.4 milligram of folic acid. One point, just you keep in mind, I will come back about this iron dosage issue. Second, they talk that as the evidence are mainly from derived from low and middle income countries, its applicability to high income countries or to population at risk of micronutrient deficiencies, for example, due to an adequate diet or food fortification program is unclear. But I think this is relevant for high income country, not for country like India. And the last point, this is very important point, and I think you may come across this in day-to-day practice. Most of these multiple macronutrients, including Unimap, contain 30 milligram of elemental iron. But WHO, on the other hand, recommends antenatal supplementation containing 60 milligram of elemental iron in population where anemia is a severe public health problem. And severe public health problem means prevalence is more than 40%. And India is such country. In India, prevalence of anemia is more than approximately 50 to 55%. Therefore, WHO suggests that countries should consider their population magnitude and distribution of anemia and its nutritional determinants, that is iron deficiency, as well as the magnitude and distribution of the complex of low birth weights and its component like preterm and small for gestational age, or combination of these when undertaking any research in the context of this recommendation. So this last point is very important for India, not as a clinicians, as a physician, but as public health implication. So for that, we need more larger this kind of seminar and discuss with the policy or decision maker that whether to implement or not. Thank you.
Thank you very much, Dr. Randi. I think we have come to the end of the webinar. We know that multiple micronutrient supplementation of pregnancy has always been in the limelight. It's been a great debatable topic, but we need to understand that the requirement may be very small, but deficiencies have been associated with significant outcomes in pregnancy, especially in the fetus. So in this part of the world where nutritional deficiency is so highly prevalent, we are quite sure that they're going to be accompanying deficiency of these micronutrients. So supplementation of these gets prime importance. And prenatal has niacin, B6 and B12 from foods. So and of this current period in COVID, we know how much importance and focus zinc has been getting in the last at least 1.5 years. So we would like to conclude this webinar by thanking Dr. Ramani Devi, Dr. Jaydeep Tang, Dr. Kristen Hurley, Dr. Randi Chaudhary, and all the attendees who have patiently sat through this entire webinar. And it's our great pleasure also to be thanking FOGS to have been a part of this wonderful international webinar. Thanks to one and all, and good night to those in India, and good morning to you, Dr. Kristen.